Today we're going to talk about the respiratory system, and we're going to start with allergies. When we are exposed to allergens such as pollen, pet dander, or dust, our immune system goes into action and eventually releases histamine. So the medications that we typically use to treat allergies are called antihistamines. Antihistamines work on the H1 receptors. They are antagonists, so they block the activity of H1 receptors. The first medication that we're going to talk about is a first-generation over-the-counter antihistamine, and that is Benadryl. The generic name for Benadryl is diphenhydramine. Before we move on to the second-generation antihistamines, I want to talk about some of the side effects associated with first-generation antihistamines and the mechanism of action. So histamine causes vasodilation and leaky capillaries. So you end up with flushing of the skin, edema. Eventually it can lead to low blood pressure. It also causes some bronchoconstriction, and histamine can have an effect on the central nervous system as well, causing problems with cognition, memory, and our sleep cycle. Other actions of histamine include itching, pain, mucus secretion. So our H1 blockers, or our antihistamines, are working to block those effects. They're used for allergic rhinitis, or running nose, sneezing, runny eyes, itching, or localized swelling. Because histamine plays a role in our CNS, there can also be some CNS side effects, like confusion. Also, other side effects include sedation, dizziness, fatigue, stomach upset. But the most common side effects associated with first-generation antihistamines are the anticholinergic effects. And we have a little acronym for remembering the anticholinergic effects, and that acronym is ABDUCT, A-B-D-U-C-T. And you can think of that as the antihistamines pulling the water away or driving it away, abducting the water, and leaving you very dry. So the typical anticholinergic side effects include A, anhidrosis, or lack of sweating. B stands for blurry vision, and that is caused by dry eyes. D is for dry mouth, and U is for urinary retention. C is for constipation, and T is for tachycardia, or increased heart rate. So just if you remember the acronym ABDUCT, to remember side effects associated with anticholinergic medications, including antihistamines. Second-generation antihistamines are less likely to cross the blood-brain barrier, and they have a lower affinity for H1 receptors in the central nervous system. So second-generation antihistamines have less side effects, less anticholinergic effects than the first-generation antihistamines. Second-generation antihistamines should not be confused with H2 blockers. If you remember from our discussion on the GI system, H2 blockers like ranitidine and famotidine block H2 receptors. Second-generation antihistamines still block H1 receptors. The two medications that we are going to learn in the second-generation antihistamine category are Zyrtec, whose generic name is cetirizine, and Claritin, and the generic name for Claritin is loratadine. And you'll notice the stem on loratadine is tadine, T-A-D-I-N-E. And going back to our H2 blockers, ranitidine and famotidine, they had a similar ending of T-I-D-I-N-E. One way that I keep these straight is that the H1 blockers, the ending is TA, and H2 blockers, the ending is TI. 1 comes before 2, and A comes before I. So hopefully that'll help you keep them straight as well. Additionally, there is a product available that combines a second-generation antihistamine with a decongestant. We will talk more about decongestants in just a moment. Claritin D is just one example of an over-the-counter antihistamine with decongestant. The generic name for Claritin D is loratadine with pseudoephedrine. So we've talked about antihistamines and the fact that they block H1 receptors, and that second-generation antihistamines have less side effects than first-generation antihistamines. One important thing to remember about antihistamines is that they are most effective if they're taken before symptoms appear. For people who suffer from allergies seasonally, they should take an antihistamine every day, regardless of if they are having symptoms, to help prevent the effects of histamine. For people who suffer from allergies all year round or perennially, then they should be taken every day. So now we will move on to the OTC decongestants. All these are also known as sympathomimetics because they activate alpha-1 receptors on blood vessels in the nose. That causes vasoconstriction, and it reduces the swelling and congestion associated with allergies and other things that can cause congestion in the nasal cavity. The thing about these medications is that they are not selective, so they can have a sympathomimetic effect on all alpha-1 receptors, and they should be avoided in patients who have uncontrolled hypertension and other cardiovascular disease because of their ability to cause systemic vasoconstriction. The most commonly used decongestant is Sudafed, and the generic name for Sudafed is pseudoephedrine. And another over-the-counter decongestant is neosynephrine, which is available both as a tablet and as a nasal spray. The generic for neosynephrine is phenylephrine. Another medication that's available as a decongestant nasal spray is Afrin. And the generic name for Afrin is oxymetazoline. As a reminder, patients with hypertension should avoid decongestants. One thing to know about decongestant nose sprays is that they can cause rebound congestion. So these medications should only be used for a maximum of 3 to 5 days. Otherwise, the congestion is going to become worse and they will not have as great of an effect. And that rebound congestion can be really hard to overcome. One thing that you can do is wean yourself off of the sympathomimetic or the decongestant nasal spray and start using a glucocorticoid instead, which we'll talk about those more in just a moment. So for 2 to 6 weeks, use the glucocorticoid, and you can use the decongestant sparingly for that first week of switching to the glucocorticoid. The most common side effect of oral sympathomimetics like pseudoephedrine is CNS excitation. So you can get some of that irritability and just hyperactivity when taking these medications. So now we're going to come back up to the OTC allergic rhinitis nasal sprays, the glucocorticoids or steroid nasal sprays. Like I had mentioned before, these do not cause rebound congestion, and intranasal glucocorticoids are the most effective agents for treating and preventing allergic rhinitis. One agent has not been shown to be more effective than the other, and there are several available over the counter. The one we're going to talk about now is Nasacort, and the generic for Nasacort is triamcinolone. Another common one that we will see again later when we talk about asthma is fluticasone or Flonase, and that is another over-the-counter allergy nasal spray that is available. The glucocorticoids intranasally don't have a lot of systemic side effects. Their most common side effects include a burning or itching sensation when it's applied in the nose. It can also cause some drying of the nasal passage, a sore throat, possibly a nosebleed, and then a headache. But the topical or the intranasal glucocorticoids do not have as many systemic side effects that are associated with oral glucocorticoids. Now we're going to talk about cough medications that are available over the counter. And this says mucolytic, but it's actually an expectorant. So there's one product that's available over the counter. It's available in multiple different forms. You can find it in Mucinex DM tablets, Robitussin DM, and also in some other combination cough and cold medications. It combines an antitussive, or a cough suppressant, with an expectorant. And the generic for these medications is guaifenesin and dextromethorphan. The guaifenesin works as the expectorant, and it increases the flow of respiratory tract secretions. Now that seems a little bit backwards, but what we want to do is break up that chest congestion and get it out of your system so that the congestion will go away. So guaifenesin is the expectorant, and then the antitussive is the dextromethorphan. It's also available by itself in the Delsum cough medication. There are also some prescription-only cough medications, and the one that we're going to touch on is Cheratusin AC, and that's an antitussive and an expectorant again. So that's guaifenesin, just like before, and then the cough suppressant in Cheratusin is codeine. So now that we've covered all of the over-the-counter medications available to treat allergies, we're going to move on to asthma. The symptoms of asthma result from inflammation and bronchoconstriction. So drugs that we're going to talk about to treat asthma are targeting these two properties of the asthma disease. The first are the oral steroids. And like I mentioned before, oral steroids have a high potential for toxicity. So their use should be limited, and it should be for a brief period of time, usually less than 10 days, and then the patient would be tapered off of that medication. Oral steroids are typically only reserved for cases where symptoms cannot otherwise be controlled. So they're used for exacerbations of asthma, or times when the condition of asthma gets worse. We're going to talk about two oral steroids. The first is Medrol, or methylprednisolone, and the second is Deltazone, or prednisone. Now, it may seem easy to remember these steroids as having a zone ending, S-O-N-E, but the actual stem of these two words is pred, P-R-E-D. And some of those side effects that are associated with steroids include adrenal suppression, osteoporosis. They can cause hyperglycemia, which can be dangerous in patients who have diabetes, peptic ulcer disease, and then there is some evidence of growth slowing in young people. So initially their growth seems slow, but the studies have found that their full adult height does not appear to be affected. So the steroids are used to treat inflammation, and if we're not going to be taking them orally, we need to get them into the system another way. So asthma and COPD are both typically treated with inhalers. And there are inhalers that both target inflammation and the bronchoconstriction. So take a minute to look at this list of inhaler types, and then we will discuss each of them and how they are different. We'll start with the metered dose inhaler, which is the type of inhaler that everyone is probably most familiar with. It's the type of inhaler that you see on TV or in the movies when somebody is having an asthma attack. And it's that device where the canister needs to be pushed down in order to activate the medication. So it is a pressurized, patient-activated inhaler that requires good hand-breath coordination. With a metered dose inhaler, the patient would start to slowly breathe in prior to pushing down on the canister. For some patients, it's more difficult for them to take that breath and push that inhaler at the same time. So a different type of inhaler, or the dry powder inhaler, is a breath-activated inhalation system. Tiny particles of the dry powder are sharply and deeply inhaled into the lungs by the patient. And the newest form of inhaler type that's available on the market is the Respimat inhaler. It is also activated by the user with a push of the button, but it delivers a very fine mist without propellants, and since that mist is so fine, more of the medication reaches the lungs instead of getting stuck on the patient's tongue or the back of their throat. And then finally, inhalation medications can be delivered via a nebulizer. A nebulizer is a machine that turns the drug into a very fine mist. It's inhaled through a mask or a mouthpiece. In the inpatient setting, because the nebulizer has shown to get most of the medication to the lungs as compared to an inhaler, patients' breathing treatments are usually given via nebulizer. And although nebulizers are very small and portable, sometimes it's not very convenient to sit there for 10 to 15 minutes while the medication is being given, which is why inhalers are used more frequently in the outpatient setting. So now that we understand how these different types of inhalers work, we're going to talk about the different medications that are available. There are many different inhalers available on the market. Some of them are single ingredients, many of them are combination ingredients. Some companies have multiple different inhaler types for the same medications. So the ones that we're going to discuss today are just a few of the medications that are available. The first category are the inhaled steroids combined with the beta-2 receptor agonists. And these beta receptor agonists are long-acting agents. So these are sometimes referred to as LABAs, L-A-B-A, for long-acting beta agonist. The steroid, like we mentioned before, targets inflammation, and the LABA is targeting the bronchoconstriction. So the goal of these medications is to dilate the airways. The two that we're going to discuss are Symbicort and Advair. The generic for Symbicort is budesonide, the steroid, combined with formoterol, the beta receptor agonist. Advair's generic is fluticasone, which is the steroid component, and salmeterol, the beta receptor agonist. You'll notice that both of these medications, formoterol and salmeterol, both end in terol, T-E-R-O-L, and that is a stem that you can use to recognize beta receptor agonists. However, some beta receptor agonists are long-acting, and some of them are short-acting. And I don't have any good tricks for remembering which ones are short and which ones are long. One important tip for patients who are taking inhaled steroids is that they must be told to rinse their mouth after each use. Glucocorticoids can cause thrush or oral pharyngeal candidiasis, so rinsing the mouth gets that out of the mouth area and prevents that thrush. And also, the glucocorticoids can cause hoarseness of the breath and some throat irritation. So rinsing the mouth helps with that as well. Patients with asthma should not take a long-acting beta agonist alone. LABAs are associated with increased asthma-related death if used alone, so they must always be used with a steroid. This is only true for patients who have asthma. For patients who have COPD, it has been shown that long-acting beta agonists can be used alone, and the latest COPD guidelines do not recommend using a steroid as monotherapy in patients with COPD, and they instead recommend starting with a long-acting beta agonist and then adding a steroid later if needed for step-up therapy. So, should patients with asthma take a LABA alone? The answer is no. But what about a patient with COPD? Yes, they can, and they should. Then there are inhalers that contain steroids alone. One of these is the Flovent, and Flovent is available as an HFA or a metered dose inhaler, as well as the Flovent Discus, which is a dry powder inhaler. The generic name for Flovent is fluticasone. And you'll notice I have written here a third brand name for fluticasone, and that is Flonase, and that is the intranasal glucocorticoid that we discussed before for treating allergic rhinitis. So now we're going to move on to the short-acting beta receptor agonists, or SABAs, which are also known as rescue inhalers. Patients with asthma and with COPD should be on a maintenance inhaler, like a long-acting beta agonist with a glucocorticoid, and then they would have a short-acting beta agonist available to them in case of an emergency if they have an asthma attack. The most commonly used short-acting beta agonist is albuterol, and you'll notice the terol ending again there. Albuterol is available on the market in several different brand name inhalers, including ProAir, Proventil, and Ventolin. Commonly, SABAs are prescribed with the directions to inhale 1 to 2 puffs every 4 to 6 hours. Since beta agonists work to open up the airway, if the patient is instructed to take 1 to 2 or 2 puffs, they should inhale the first puff, wait about a minute, and then inhale the second puff, giving the time for the airway to be opened up and have better penetration with that second puff. Albuterol is also available combined with an anticholinergic, and that's available both as a nebulizer solution as DuoNeb and as a Respimat inhaler with Combivent. The generic name for both of these medications is albuterol with ipratropium. There's also an anticholinergic, more than one, but the one that we're going to talk about by itself, and these are long-acting medications and are used for maintenance instead of rescue therapy. The generic name for Spiriva is tiotropium. You'll notice both with ipratropium and tiotropium the same ending, TROPIUM. And these anticholinergics work by reducing bronchoconstriction. I want to move on to another different class of medication, and this is another oral medication, so we're moving away from the inhalers, and now we're talking about a pill that somebody would take by mouth, and that is Singulair. Singulair is a leukotriene receptor antagonist, and its generic name is Montelukast, and the ending there is Lukast, Lukast. And you'll notice that Lucast looks a lot like leukotriene. Singulair is approved for treating or for preventing the symptoms that go along with asthma, allergic rhinitis, and exercise-induced bronchospasm. Singulair will not stop an asthma attack. It is given once daily in the evening, and it's given in the evening to prevent nighttime awakenings for patients who have asthma. And although it's approved for exercise-induced bronchospasm, it does not work quickly, so a SABA, or short-acting beta agonist, is preferred. One rare side effect that's associated with Singulair is changes in mood. So although it is rare, it should be communicated to the patient. A lot of times, people who are taking Singulair are children, so it's important to let the patient or their parent know to watch out for these changes in mood. The last agent that I want to talk about for treating asthma is Xolair. And Xolair is a biologic agent, monoclonal antibody, which you'll recognize from the ending of its generic name with MAB, and its target is IgE. And IgE is the antibody that's responsible for the allergic response in our bodies. Xolair's generic name is omalizumab, and it is only approved for allergy-related asthma since it is targeting IgE. It's only to be used in patients older than 12, and it has a black box warning about anaphylaxis. So Xolair, which is an injection, is always administered by a healthcare professional in a setting where an agent to treat anaphylaxis is available. Anaphylaxis is a severe allergic reaction. Although histamine plays a role in all of the mild allergic reactions that we've talked about, it plays a very minor role in anaphylaxis. The medication of choice to treat anaphylaxis is epinephrine, and the brand name that you may recognize is EpiPen, which is available in the outpatient setting. Anaphylaxis can develop within minutes of allergen exposure, so people with known allergies like to peanuts or to bee venom should always carry an EpiPen on them so that it can be administered as soon as possible.